Cincinnati College of Medicine, and then did his internal medicine residency at Northwestern University, his cardiology fellowship at Loyola, and then a research nuclear medicine fellowship at the Mallinckrodt Institute of Radiology and at Washington University in St. Louis. And he joined the faculty there and then kind of rose through the ranks as now a professor of radiology and medicine, and currently the senior vice chair and division director of the radiological sciences for Mallinckrodt Institute of Radiology. He directs the Mallinckrodt PET Radiotracer Translational and Resource Center, which is an interesting center funded by the NIBIB through a P41 grant. And it focuses on the design, development, training, and dissemination of radiotracers for the detection of cellular inflammation. Rob is also the MPI on 3 other active R01s, including one with Mayron here at Yale. And as you know, he's the editor-in-chief of Circulation Cardiovascular Imaging. And Rob has really been a pioneer in the area of cardiac PET imaging and the advancement of cardiovascular molecular imaging and in translational research in general, and has been successful uniquely in translating several novel radiotracers to first-in-human studies. And the focus of his work over the years has been on sort of the development validation of PET imaging for quantitation of myocardial metabolism, and then more recently in the area of developing novel radiotracers for the evaluation of inflammation and oxidative stress, and has a unique position as the coordinator in North America for a Leduc Foundation grant, or a network, which is focused on inflammatory fibrosis access in the setting of advanced cardiac remodeling and sort of translating basic mechanisms into new diagnostics and therapeutics. And so today he's going to present his talk on the changing landscape of myocardial inflammation and imaging. It's a pleasure to have you here, Rob.
Al, thank you very much for the overly kind introduction. I'm glad the lecture is being recorded. I'll have to play that back a few times. That was very nice of you. And it's always great to speak, you know, it's such a prestigious institution. Have many friends at Yale, obviously, you know, home of nuclear cardiology. And so this is just a real honor. And as Al said, I'm going to talk a bit about how detection of myocardial inflammation is really changing and evolving and what the future might hold. All right, we're going to do it this way. So these are my disclosures. We do have some industry-sponsored trials, as well as Al mentioned, there are other federally funded and foundational support. As he mentioned, I'm also the editor-in-chief for Circ Imaging, so the AHA, and then we do have a Siemens Biograph PET-MR research agreement, which I'm not going to talk about at all, and one patent on one agent, which we will be talking about. So what are we going to do today? Well, first I'm going to start with talking about inflammation and cardiac disease, why it's important. It's a systemic disease process. Then we'll jump to what is the role of imaging? What are we doing now, but what are the challenges that we still have? And how then do we develop these new tools that allow us to overcome these challenges and unlock more about how inflammation plays a role in cardiac disease? Well, I mean, what is easy about inflammation is it involves every cardiac disease, at least that I can think of. And I've kind of summarized them on the slide. I'm not going to go through them all. But the inflammatory processes are involved either as a primary event, such as a myocarditis, or it can be a secondary event, such as following aortic stenosis, things like that. But it again plays a central role in almost every disease process. So by targeting it, we can truly understand more about the mechanisms of cardiovascular disease. So let me start a little bit backwards on this a little bit and say, well, why are we so interested in imaging of inflammation if we don't have tools to actually treat the inflammation? And the answer is we still don't have great tools. We do, but they are developing. This is, as everyone has seen before, from the Cantos trial that looked at using canakinumab to treat patients post-ACS. This is an IL-1 beta blocker, and what was done was to try and reduce the inflammatory process in patients who had a acute coronary syndrome, because we know that they have coronary syndromes beget more coronary syndromes, and inflammation probably plays a role. And what they found was that indeed, when you treated these patients with this drug, you did decrease cardiovascular incidence, the primary endpoints, as well as improve survival. Problem was that the relative risk reduction was pretty low. I mean, it wasn't overwhelming, and there was an increased incidence of fatal infection and cost of pretty expensive drugs. So this is not one that was going to achieve widespread use. But it did at least point to the direction that anti-inflammatory therapies that are fairly aggressive may be of benefit. And if we look at that more broadly for myocardial disease, this is a summary from a review in Nature that looked at various types of anti-inflammatory therapies and in the treatment of patients with heart failure with reduced ejection fraction. And as you can see, that in general, there wasn't much of an effect. And except for the Cantos trial, which we talked about the coronary events, but in fact, there was a significant trend for a dose-dependent reduction in the incidence of primary endpoint and as it relates to heart failure. Now you'll say, well, if you look at all this data, you would say, well, I guess these agents just don't really work, and we really don't have good ones yet. I think one of the issues we have is that we're giving these agents too broadly. We're not able to find the true patients who would benefit from them. What you really want to know is which agents truly have a pro-inflammatory phenotype that relates to the heart itself, maybe not just systemic inflammation. And by identifying those patients and then showing that you're engaging the target of interest, you're treating and when that engagement leads to an improvement, we may in fact be able to do better with these types of agents if we can better identify those patients who would actually benefit from the drug to begin with, rather than giving it more broadly. So another point, though, is beyond the therapies that are coming and why we need an imaging approach to help us with those therapies, is to understand how inflammation impacts the heart. What are the processes? Because very often we just think about inflammation as one process, myocardium alone, but in fact, it's a highly complex interplay of numerous factors. Again, this is from the same review, but it just shows you that once the heart is injured, either directly, either from a pathogen or from injury, this leads to an activation of various pattern recognition receptors, which in turn stimulate all of these inflammatory responses within the myocardium, which in turn activates innate immunity, meaning your hematopoietic system with monocytes, macrophages, and so on. And these also produce other cytokines and chemokines, which then activate the adaptive immunity system. Again, so now we'll get particularly B cell, but T cell activation, all of which then will have a significant role on the myocardium, either in terms of its inflammatory destructive response or in terms of its reparative response. So the point of the slide is the following, is that we need to be able to begin to understand all the different processes as they relate to inflammation, not just say, pick one cell and say, okay, this is what we're going to go after. And so, and it also says that because inflammation is systemic disease, imaging that we want to perform may have to go beyond just looking at the myocardium, but looking at the whole body. Now, as Al mentioned, I spend most of my life in the PET world, and I'm going to spend most of my time in this talk on PET, but I do want to mention, obviously, there are other techniques, specifically MR, that have been used to look at tissue inflammation. I mean, we use it routinely to identify patients with myocarditis. Again, using the Lake Louise criteria from 2018, the major difference here from 2010 is they've added all of the multiparametric T1, T2 imaging, and extracellular volume measurements in addition to the standard early uptake of gadolinium, late gadolinium, and T2 weighted imaging. So these are the current criteria that are used for MR. But I would again highlight that these signals that you're seeing with MR are not specific for inflammation. You're inferring there's inflammation based on the pathologic response that you're seeing. And just again to highlight that you can do fairly well in detecting acute myocarditis. This is just a review from Friera and colleagues, just showing the size of the bubbles is how much data there is, and then as the bubbles go up, it's how more accurate you are as an area under the curve, using the various criteria in terms of like the standard Lake-Louise criteria. If you just add in different other components, just showing that it does do pretty well though for at least acute myocarditis. So what I will talk today a bit more about is what do we have available to us both currently and in the pipeline as it relates to detection of myocardial inflammation, and where do we have to go next? So our main, if you will, our main tracer that we use all the time is FDG. It's kind of the main tracer we use for almost all disease. And it's based on the known change in metabolism that occurs when you have a activation of either innate immune cells, such as macrophages, as well as the activation of an adaptive immune cells, such as T cells. So as you see here, when one sees activation to an M1 phenotype, it's kind of an old term now, but an M1 phenotype, one sees a dramatic increase in glycolysis. You see the same thing with the activation of your T cells. Again, they can be through different pathways, but the bottom line is that the activation of these cells leads to an increase in glucose use, and thus the thought of when we see increased FDG signal, we are seeing increased inflammation. So from a clinical perspective, how are we using FDG at this point? Well, we're using it primarily to detect cardiac sarcoidosis, cardiac device and prosthetic valve infection, to large vessel vasculitis, as well as myocarditis. I'm not going to go through all the examples here, but just to highlight where it does work, and then we're going to talk a bit about why it doesn't work. So let's talk about sarcoidosis. As the group knows, multisystem disease, non-Casein granulomas is the pathology. Now, most patients have pulmonary involvement, fewer patients have cardiac involvement, and it's most likely that we may be underestimating this amount without imaging, but still a significant number will have cardiac involvement. Bottom line is that when patients get cardiac sarcoidosis, mortality rate is high. Luckily, we're moving away from the Japanese criteria, now using more of an imaging approach because the Japanese criteria weren't perfect. Most important though, the clinical presentation, non-specific, difficult to diagnose, biopsy is not helpful because of sampling issues and so on. So it is important though for us to be able to detect what's going on because of we keep getting this, I don't know if I have something showing up on my screen that I'm writing on. Hopefully that yellow will not keep popping up. But the reason why it's important to diagnose is not just because to know what the disease is, but we now are getting increasing numbers of therapies that should help us with the treatment of disease. And the problem is that most of these therapies are toxic in one way or another. So you do want to be able to know that you want to again, identify the patient that will benefit from the therapy. Let me try something here. This is going to drive me nuts. Just going to take them all off. Oops, that didn't work. Let's do this. Okay. So here's one of our patients that it's a couple of years old slide now, but I think it highlights the potential role of both MR and PET. Female presented with suspected cardiac sarcoid, was acutely ill, was having recurrent VT. MR scan shows you the late gadolinium enhancement, or in the basal septal anteroseptal wall. When you did the PET study, you see bilateral lung FDG uptake consistent with pulmonary sarcoid, and the uptake in the anterior apical wall consistent with myocardial sarcoidosis, and this is just an overlay confirming that diagnosis. And clearly, these two approaches are complementary. This is just work from the Brigham group, which showed very nicely that when you had both MR evidence of cardiac sarcoid here in the late gadolinium enhancement and evidence of increased FDG uptake in a patchy pattern, high probability of cardiac sarcoid. And then as you move down, where you begin to get discordances, the probability drops, to less probable to go all the way down to much less likely to be having disease. So what they were able to go on and show was that if you added the PET to an MR, 45% of the patients were reclassified into a higher or lower risk group. And they were correct on that 80% of the time, and it drove how the therapy was going to be used. So the point of the slide is that we probably need both approaches if we're going to be detecting cardiac sarcoidosis in patients. We also know that the degree of inflammation has prognostic implications. This is just showing a perfusion and FDG map of patients with sarcoid, and the bottom line is that, as you see, is that when patients have more uptake and there's more variability in that uptake, they in fact have a higher, a worse prognosis related to their disease. We also know that we can use this approach for following patients for therapy. Again, same study just showing that when you had marked responses in immunosuppression, meaning the FDG uptake went down, there was an increase in New York Heart Classification class, as well as an improvement in function. Conversely, when the response was less pronounced, you didn't see that beneficial effect. And this just highlights that data more so, that no matter what kind of measurements you did, those patients that respond to the immunosuppression did better as it relates to the change in ejection fraction. In fact, it was a better predictor when you saw the myocardial response versus, let's say, a lymph node response. So again, using the molecular imaging approach to not just prognosticate, but identify those patients who are most likely to benefit from that therapy. Just one quick example from another paper, just showing that not all FDG uptake in the setting of a clinical setting where you're worried about sarcoid is in fact sarcoidosis. This is just one example, again, where you see very nicely the increased FDG uptake, patchy in nature, and so on. But when the biopsy, when the heart was explanted, and they looked at it, it was in fact a arrhythmogenic cardiomyopathy. It was not sarcoidosis. So we always have to keep in the back of our mind, we're seeing a general signal of what we think is inflammation, but it may not be specific for cardiac sarcoidosis. The other place where we're using it most commonly is cardiac device infection. Major problem, morbidity and mortalities, significant costs, and it's very difficult to diagnose. Particularly blood cultures are inconclusive. Morphologic imaging can frequently be inconclusive as well. And just a nice review from Baskin and Wei-Lin Chen, just showing the different places where we use FDG PET, such as the early detection of valve infections for prosthetic valves, as well as for device infections, just such as pacemakers, as well as for LVAD infections. And again, where it's an additive to the other morphologic measurements. Here's just one page showing an example from our place. Again, a lot of wording here. Long and short is a patient underwent emergent repair for a type A aortic aneurysm. Had to go back for a second surgery because of severe aortic root regurgitation. got a bioprosthetic valve, as well as a bypass graft to the right coronary artery and a cable graft to the left coronary artery. Then developed sternal osteomyelitis, had to go back for revision. Subsequently got an echo, which was limited, and they couldn't see the valve well. TE was concerning for infection of the graft, but the valve still looked fine, so an FDG PET was asked for. So here's the images of the FDG PET, just showing you the increased uptake in the sternum. You can now see that activity coming down into the mediastinum, so there was clearly a fistula being developed. And this development, you could see as we stepped down, became more progressive, where you now had inflammation, increased FDG around the aortic root itself, the aortic valve itself. And so in this case, it was clear the patient had also involvement of the aortic valve, had to go back for surgery again. So again, to highlight, it is incredibly useful in prosthetic valves, not native valves. One study a few years back just showed the ability of FDG PET, in this case with a patient again with aortic valve infection, just we could classify positively in a definitive way 18 of 70 patients, and possible to rejected in 45 out of 70. The other strength of the approach is not just detecting infection at the valve, but because we can do whole body imaging, you can also detect septic emboli, such as in this patient here, we had numerous examples of septic emboli. So because of that, at least in the European guidelines, if you have a prosthetic valve and regional suspicion for infection, inflammation imaging with nuclear methods, primarily FDG PET, is now recommended. So I've now given you what I think is a pretty compelling story for FDG. Why are we looking for other agents? I think this slide kind of summarizes it, because I'm going to show you three different sets of images, and you tell me which one has sarcoidosis. So three different studies, different people. Which one of these three has cardiac sarcoid? Well, if you look, it's normal pattern to the left, cardiac sarcoid in the middle, cardiac ischemia, myocardial ischemia on the right. This is just some of the data that demonstrates that we know, we showed many years ago now that in fact you can get this posterior lateral uptake of FDG even when you fast somebody normally. So, and that's what you're seeing right here. You also know that with ischemia, the heart switches from fatty acids to glucose because of decrease in beta oxidation. And so in this case, DeWalker-Janes showed very nicely that in the areas of perfusion defect, you got the increase in FDG uptake consistent with ischemia. So the point being is that when we see these patterns, we still are scratching our heads and saying, is this really a pattern of inflammation, or are we getting some type of false positive study? So that's one of the real limitations of FDG. So what are other approaches that are being looked at? Well, one approach is to look at the TSPO receptors, which are within mitochondria, and thought being here that inflammatory cells have an increased mitochondrial burden and activity, and that may be a way to detect increased inflammation because you'll see an increase in signal. This work was done by Frank Bengel's group with James Thackeray, and they now have F18 agents, and these are trying to be commercialized. So it's not like this is just something that'll stay in the research lab. But what they showed here, and this is a patient post-MI, is that you see the decreased perfusion, this anterior septal apical wall, that's associated with increased TSPO uptake, which is suggestive of or consistent with increased macrophage activity within the anterior apical myocardium consistent with inflammation. The unique aspect of the study was not just using TSPO, but they also did imaging of the whole body and the brain, and they were able to show that you had increased inflammatory patterns in the frontal and temporal cortex of the brain of these patients compared to controls. It's just a map where you have the controls laid out and you have the patients on top, and these are the differences where the patients had different TSPO activity. So we all know about heart-brain interactions, and that MI can beget stroke and also beget potentially cognitive decline down the road. This is just one example of how imaging might be able to help us in that space with TSPO. The problem with TSPO agents is that because it's really looking at mitochondrial mass and more than anything else, we know the myocardium has lots of mitochondria. So how you're going to differentiate in a non-ischemic pattern would be very difficult because you don't have the regionality to detect the TSPO activity that's specific to the inflammation. Another approach is to use the somatostatin 2 receptor imaging agents, in this case dotatate, dotatalk, which have been commercialized for neuroendocrine tumors. Thought being here again that macrophages have increased expression of the somatostatin 2 receptor. What isn't fully clear though is the macrophage that's expressing it pro-inflammatory or not? And so that lack of specificity is a limitation. But in this study by Paco Brava, they just looked at a small group of patients. When patients had diagnosis of sarcoid, got FDG, and then got a dotatate image subsequently. So it was a retrospective study. It's really quite wide in the range of patients got the two studies, sometimes 2 or 3 months between the FDG and the dotatate. But just showing an example here of a patient, you see the late gadolinium enhancement more epicardially. You see the FDG showing you the posterolateral uptake. And if we then look at the dotatate, we see FDG as well in the basal anterior wall, dotatate, basal anterior wall, and again in the lateral wall. So it looks like the dotatate kind of was concordant with the FDG. This is just an example over here where after a patient was treated, as though they only had one, that the dotatate signal went down. Very few data we have on this. I think this was like 1 or 2 other studies. The big problem is there's real discordance between the FDG signal and the dotatate signal in numerous patients. So that then begets the question, is the dotatate insensitive to an inflammation, or is FDG overcalling the inflammation? And that has now been resolved. And so in this study here, again, just showing you one biopsy where they were able to show that normal myocardium didn't have any somatostatin 2 receptor expressing cells. Here you can see it in the lymph node around the germinal center. You can see it here in the myocardium. So there was expression of these cells. There are increased number of these cells expressing somatostatin 2 receptors. I'm going to skip that because I just said it. So what do we do now? I mean, I've talked about some new tracers that are already being used, but they have limitations. What can we do instead to maybe increase that sensitivity and more importantly also the specificity of what we're looking at, given that the inflammatory response is so complex? So what I like to do is using a post-myocardial response, myocardial infarction response as a model. Let's look at that. So if one looks at what happens at here, normal myocardium, you've got monocytes, neutrophils patrolling in the blood. You've got some also in the tissue. Primarily, though, they're CCR2 negative macrophages, very few CCR2 positive. We'll come back to that. So what happens? You have injury, as I mentioned earlier before. You have, in this case, damp signals going out, and you will get stimulation and production of pro-inflammatory monocytes from the bone marrow. And these monocytes are going to be expressing CCR2, chemokine C receptor 2. Chemokines are nothing more than chemotactic cytokines in this case that, again, and the protein here is MCP1. And what it does is it goes to the bone marrow, tells the bone marrow, I need a bunch of pro-inflammatory monocytes to then get to the myocardium. We also have neutrophils coming in the myocardium. And these pro-inflammatory monocytes differentiate into pro-inflammatory macrophages, and they become kind of the wrecking crew, cleans out the debris from the myocardial injury. So if you label these cells, or you can trace these cells, you're actually looking at pro-inflammatory monocyte trafficking to the heart, and then looking at the expression of the pro-inflammatory macrophages in the heart. And as I'll show you, we've developed such a tracer here, Yongjin Wu leading the way, that actually labels these CCR2 positive cells. Similarly, another tracer is CXCR4. This is a different receptor. It is actually expressed on neutrophils. And so again, you can look at the neutrophil inflammation response. However, the difficulty with CXCR4 is that it is also expressed by CCR2 negative reparative macrophages as well as other cell types, so it's not as specific for the pro-inflammatory response. It's really a mix of the pro-inflammatory and the reparative response. Example, though, of how CXCR4 tracers are now being used in humans routinely. This tracer is also used for tumor imaging, and in Europe it's used quite extensively by labeling the CXCR4 and, if you will, synthetic, in this case it's betoxifer, labeled gallium-68. And so Frank Bengel's group looked at a group of patients post-MI, and what they found was that, not surprisingly, you have this wide range in the infarct to myocardial ratio. And you also have the perfusion scores, doesn't really correlate with the CXCR4 uptake. But what you do see is that the CXCR4 uptake does correlate with the level of enzyme release. It also correlates with CRP, an inflammatory biomarker, and it's inversely related to the LV ejection fraction. The higher the inflammatory response, the lower the ejection fraction. And this is both initially and in follow-up. A couple of examples shown here. One patient who didn't have much CXCR4 uptake, as opposed to a second patient who did. So this is, again, one drug that's a possibility, but as I mentioned on the previous slide, because of the non-specificity of the agent, it's probably going to overcall the extent of inflammation. So as I mentioned a couple slides ago, Yongjin Liu started looking at how do we measure CCR2 expressing cells within tissue. And again, the reason being is when there's damage to tissue, the MCP1 or CL2 goes to the bone marrow and to stimulate the production of pro-inflammatory monocytes. And they also then traffic to the spleen and then traffic to the different organs as shown here. And it's been a target of drug discovery for quite a while. What's interesting, though, is we really didn't know how much of the CCR2 positive cells were actually expressed in myocardium. So Corey Levine, using biobank tissue, did just single-site seq data showing very nicely that if you break out the different cells within myocardial samples, in this case, 2 acute MIs and chronic ischemic cardiomyopathy, you have your T cells, NK cells, endothelial cells, fibroblast mast cells, muscle cells, and macrophages. If you then use your antibodies to detect where are CCR2 positive cells, well, they're in this family or this neighborhood. This neighborhood is monocytes and macrophages. So it makes sense then that if we look at CCR2, we're looking at that population of cells. If you look at those cells, these specifically, what does one see in terms of various other proteins associated with it? And you see all these pro-inflammatory proteins associated with the CCR2 positive cells, as opposed to the CCR2 negative, which have more reparative, if you will, types of expression. So with that in hand, Yongjin, working with Chris Comdier from Inserm, developed a peptide that actually binds to the CCR2 receptor. And using that approach, Yongjin was able to label that peptide either as a single peptide radionuclide or within a nanocluster, so that you had multiple targeting moieties on the nanocluster. The radionuclide was copper-64. What they then did as a first pass with Dan Kreisel, a CT surgeon, what they did is they looked at that in post-lung transplant animals. Immediately post-lung transplant, if you go into a non-syngeneic animal, you have an immediate inflammatory response due to the rejection process. So if you look here, they transplanted here into a wild type to wild type, versus a wild type to CCR2 negative animal, one sees here that in the wild type to wild type, very high signal, consistent with the rejection process, where here, these animals will still be rejecting, but because they're CCR2 knockout, you're not seeing as much of the pro-inflammatory response. And this continues all the way through various time points. If you then compare the uptake, you see that the native is much lower than the donor at all the different time points in the CCR2 negative, just again driving home that you get a decreased response compared to when you look at the wild type to wild type. So here we have a more dramatic response, higher CCR2 uptake versus the CCR2 negative. And just showing you get similar responses if you use the gold nanoclusters. So the next question became, well, can we look at patients post-MI? So working with Corey, Goshen Hugh, who works with us in our group, they took a post-MI animals and classic ischemia reperfusion and did FDG and CCR2 imaging with the probe, although here was radiolabeled gallium-68, not copper-64. And what they found was if you look at sham animals, you don't see any specific FDG uptake, whereas here in the MI, you can see the reduced FDG uptake. Again, if you look at sham, you don't see much FDG compared to the MI. And if you look at the MI animals, you see the increased CCR2 probe, which correlates very nicely with where the FDG uptake signal is low. If you then look at flow cytometry, we see this progressive increase in the blood of CCR2 positive cells. If we also then look at the tissue and look at immunohistochemistry for CCR2, we see progressive increases in CCR2 expressing cells. If we look at the ejection fraction, we see that as the more uptake of CCR2 positive cells, the more inflammation, the worse the hearts did, whether it be on a regional basis or a global basis. So that's fine and dandy, but do we know if that's going to work in the human heart? So here again, Youngjin and Corey looking at biobank data, looked at Youngjin's probe and on tissue using autoradiography. So here you just have the CCR2 labeling cells, the CD68 cells, DAPI as your control, showing you the increased CCR2 in a post-MI myocardial sample. This CCR2 correlates very nicely with the H&E, showing you the damage in tissue. You can also see the CD68 overlay. And in fact, if we look here, we see significant CCR2 positive cells co-localizing with CD68 cells, which are representative of the macrophage population. And if you look at the autoradiography, it actually correlates fairly nicely with the increased activity here versus here versus here. And these are just two other radiographs from ischemic. I'm sorry, this is CEA. What am I talking? So this is CEA here showing you the correlation. But here, the ischemic cardiomyopathy reduced autoradiography signal compared to the post-MI. So again, going back, because I wasn't clear here, this is carotid tissue, but again, showing the correlation of CCR2 expression with the co-localization of CD68 and the autoradiography tracks. So we've now studied about 8 or 9 patients with post-MI with this tracer, compared them to controls. And here's what we have found, is that if you take a patient, in this case, day 4 post-MI, and you look at the perfusion, you see reduced perfusion with SPECT, as one would expect. Here is the copper-64 CCR2 agent showing you the increased signal as consistent with increased inflammation. If we then look at the SUV means in the infarct versus remote zones, we see it's increased consistent with the inflammatory process, and this is higher than it is in controls. We also see that in the bone marrow. We saw increased uptake in the MI patients compared to controls, suggesting the increased production of the CCR2 positive cells, as one would expect. Not this patient, but a different patient, showing you the increased signal based on radiography, and that the signal could be blocked, meaning if we gave cold tracer, we could block the CCR2 signal, demonstrating specificity. So we're writing that up now, but we're now also starting to move towards cardiac sarcoid, because again, as I mentioned before, we would love to have a more specific agent. And just getting started with this process, Shiyu Lin and Corey are starting this in sarcoid patients. And this is just one example of why we would go this way. Here's the tissue histology for patient with sarcoid, showing you the granuloma, giant cells here, interstitial infiltrates, and so on. Here's the immunohistochemistry showing you the CCR2 is in red, CD68 is in green, and they are co-localizing fairly well with these interstitial, sorry, this mouse doesn't work great, with the interstitial cells. So showing you have increased CCR2 expression, CD68 cells are there as well, and these cells are co-localizing, suggesting that the tracer may be of use in these patients. Just a couple of examples, similar to what they did with dotatate. These patients were studied within 2 days of each other. So on top, on the left, you have the FDG signal, and the patient show the apical and infrabasilar FDG uptake. Here's a CCR2 showing you the apical uptake, CCR2 infrabasal. So they were concordant. In other cases, they're discordant. This is a case of the posterior lateral wall being hot, also more infrabasally being hot. We're not seeing anything with CCR2. So that means, is CCR2 not working? Or, and we don't know this, was this one of the false positive patterns that I showed you earlier, and we're actually overcalling the sarcoidosis? We don't have an answer, but this study is ongoing, and we'll see where it takes us. So Al mentioned P41, and I just want to give it a plug. What we're doing is we're developing a whole host of tracers to look at inflammation and its consequences, whether it be via the sphingosine-1 phosphate system, or inflammation with chemokines, as I showed you, or downstream effects with oxidative stress. We're working with groups around the country in yellow and also in Europe that are helping us develop these tracers by evaluating them, using them in their hands, telling us what works, what doesn't work. We're also providing them to groups around the country. The group at Yale has been very active in this regard, with Hilmer and colleagues looking at this for neuro applications with the S1P1 tracer. But it's really worked out well that we're now distributing these tracers and training people in their use around the country. So let me close up shop here with, I've shown you a lot of data. Where is this all going, and how are we going to use it? I mean, imaging agents are expensive to use, and we're not going to want to be imaging everybody. So here's kind of the paradigm I'm saying. This could be for atherosclerosis too. When you have a patient, you're going to be evaluating them. They're going to be, based on their data you plot from the various clinical databases, as well as the patient, other biomarkers you may have in terms of their workup, clinical environmental factors. You'll have all this from the physical exam and early blood work. What we may then be doing is looking at their blood to see, do they truly have an increase in pro-inflammatory monocytes and other cell types in the blood? And then we will then do imaging to say, yeah, we think they do. In fact, in this case, the CXCR4, there is increased imaging. We then may also want to know what are the effects of that inflammation? I didn't get into it today, but we can now begin to look at active cardiac fibrosis, one of the true outputs from the inflammatory process, using the FAPI agents. And you can then say, I got active cardiac fibrosis, but how much total fibrosis do I have? Then you can do MR imaging to then tell you, okay, I'll do my ECVs, what have you. It tells me my global fibrosis. It doesn't tell me if it's cross-linked or not. Is it something that's reversible or not? Hopefully this PET approach will. And then by doing that, we'll have a better understanding of what's causing the patient's LV dysfunction and how do we treat it, because we've specifically identified the targets that need to be treated and have a way to follow them. So let me close with this last slide. I think we talked about the importance of inflammation in cardiac disease, both in terms of the number of disease processes that are involved, that therapies are being developed, but we need imaging to help us guide those therapies. We also talked about how this is a complex disease that's both local and systemic. We talked about the role of imaging, both current approaches, whether they be MR, FDG, and that they work reasonably well, but there still are issues with specificity that we need to work through. And I went through certain tools that we're now developing, whether they be based on chemokines or other approaches, dotatate and whatnot. What I didn't talk about was that the potential of hybrid imaging, as we begin to do PET-MR, can we begin to combine these two, such as here, where we have a PET-MR of an MI with CCR2 and link gadolinium enhancement? I think those are all things that are on the table. So with that, I just want to highlight the people that get all this work done. I'm really just a spokesperson, and I've just highlighted some names in the various centers that we have, whether it be the Precision Radiotheranostics Center or the MR Center, individuals that have helped us also across departments, our facilities, which really make life much easier to get all these studies done, and the funding, the generous funding from the various governmental agencies and the Leduc Foundation for allowing us to do this work. So with that, I will stop and take questions. Thank you.
That was great, Rob. Thanks a lot. Let's see, we have questions in the chat. Mehran, you want to pose your question?
So as usual, that was a great talk, Rob. Thank you. So we have a whole bunch of tracers now in the pipeline. How do you prioritize these tracers? And then it's going to be expensive to take a tracer to humans. What are the implications there? How do you sort of address that issue of economic viability?
Yeah, I think economic viability is going to be based on the therapy that's best linked to that tracer. If you have a tracer that, if you have a target that is really a target that is interesting or important to pharma, that tracer is going to get prioritized, I think, based on just that alone. And that would also mean, sure, you have performance issues, but that would make you drive to use those to make better tracers in that regard. The other thing that will drive it to some extent will be how much we can impact the downstream costs. If we impact the downstream costs significantly, you may well end up using more than one tracer in a patient. I mean, if we think about too, the new whole body PET systems that are coming online, I mean, I think, we look at those, you could say, hey, I might be able to begin to do low dose studies with these high sensitivity systems and be able to get away with a lower, multiple tracer studies because I'll get them done quickly. Because there's a whole new field of working on low dose, low count studies. So you can do these serial studies, not have to wait each one and be able to quantify. So now you get people through quickly with just a 2-dose study, let's say. So that will also help move them forward clinically. In terms of cost to take a tracer to humans, as you know, because you and I are working closely on one, it's not as expensive as it has to be. I mean, once you have your tracer preclinically, it doesn't have to be a ton of data. Once you have that data, it is probably about $300,000 to $400,000 to figure out if that tracer has any promise at all in humans. Now, $300,000 to $400,000 sounds like a lot, but at the end of the day, with what we do, I think that's a reasonable cost to make it happen. The key is centers have to be set up to do this. We're blessed to have that, so we can move things through fairly quickly as it relates to dosimetry, toxicity, the FDA documents, and so on.
So I have a question with regard to the CCR2 tracer, and it with regard to quantification of the uptake. And have you explored any sort of dynamic imaging or kinetic modeling of this tracer? And do you see that quantitation of the tracer might be useful in evaluating therapeutic interventions?
It's a great question, Alan. And as you know, one of the challenges is that CCR2 positive cells are also in the blood. That's how they're getting there. So we have looked at that. We have, Richard LaForest has done some work, I didn't show it, modeling the data, looking at volumes of distribution, and showing that, in fact, you get very similar correlations as you do just doing SUV. I think where it may have relevance is looking at remote tissue because there your signal's not as great, so we might be able to get away with it there. But so we are exploring it. We're actually trying to improve the tracer by now looking at developing targeting probes that actually look at activated receptor, not just receptor, because we think that would give us more specificity than just looking at, quote unquote, the receptor itself.
Jeff, you have a question?
Yes, Rob, terrific talk. I'm a big fan of your work. That's really great stuff. I wanted to maybe revisit the definition of inflammation a little bit and talk about when you said some of these images, the CCR2 signal is pretty small, and wondering about that. So, you know, as opposed to our classic definition where there are neutrophils in the setting of acute inflammation, or monocytes crossing endothelium and depositing in tissues, causing edema, et cetera, et cetera. There are receptors for DAMPs and PAMPs on just about every cell. And a lot of your imaging that you've been talking about is based on macrophages in particular, a little bit neutrophils. And I'm a big believer, and I think that's incredibly important. But there could be inflammasome activation, for example, in cardiomyocytes or in cardiac fibroblasts. That is a form of inflammation, could be triggered by the release of substances, peptides or otherwise, from just a few cardiac resident macrophages, let's say. There aren't a lot of them, but there are some that are CCR2 negative, as you mentioned. So what about imaging inflammasome activation in cardiomyocytes or in, you know, tissue resident, cardiac resident cells, as opposed to a big macrophage signal? And that could that be why you get edema signaling without LGE in MR?
Jeff, thank you for the kind words. And you're absolutely right. We're looking at one component. So let me just kind of unpack that a little bit. And one of the things I did not get into was just how diverse the macrophage populations are. And so certainly, yeah, resident macrophages could be playing a role. We are developing probes that look at tissue resident macrophages so that we can look at that expression. And we're going to see where that takes us, both within cardiac, but also within the tumor microenvironment, where the immune tumor interaction is so important. With respect to the inflammasome, we also think that's important. And one of the ways that we're trying to get at that a bit is looking at it with the sphingosine-1 receptor system, phosphate receptor system, specifically receptor 2. And if you look, it plays a role in the inflammasome activation, or at least is there. So part of our mission in the center is to develop this toolbox of tracers that can look at these various groups, because the other thing I didn't even mention were T cells. They also could be there. And I think we're going to have to develop tools to look at all of them. These will all be for research, not for patient care. I'm not pushing that. And then what we'll do is we'll figure out which of those works best generic, broadly, to give us the best clinically relevant signal.
Good, thank you.
Harry, go ahead.
Rob, thanks for a great talk. You concentrated appropriately on the myocardium and didn't deal with the vasculature, which had been my hope that inflammation imaging would do a good bit with. There was the early work from the MGH and nothing much since. I've always had the hope that with the appropriate radioligand, we could look at the whole myocardium and develop an inflammatory risk index that was centered on vascular uptake without having to image either the proximal LAD or any other vessels, which has presented all kinds of problems. With these new agents, do you see any hope for looking at early athero in non-infarcted patients, who would not have inflammation in the myocardium, to get an insight into the biology and potential treatment of patients early in their disease?
No, it's a great question, Barry. And the only thing that shows up one example, carotid. We actually have an RL1 that's doing CCR2 imaging in patients that undergo CEA and peripheral vascular repair to compare the uptake of the tracer and with what we get out of tissue. And what's interesting there is there's actually very little literature on CCR2 expression in atherosclerosis. So we're now finishing up, finishing up work from a biobank where we're correlating the histology, the immunohistochemistry, the site-seq data with CCR2 autoradiography. These aren't imaged, but just to say, okay, do we understand where is these cells being expressed? What type of, where in the plaque? Because it may be it's very early on, it's not later, we don't know. And so we're learning all that now. As it relates to which agent, I'm not sure ours will be the best one, because of the blood activity. But I think there are still possibilities. I'll mention one other one. Yongjin and Pam Woodard developed the CNF cone agent, natriuretic peptide C receptor. It's increased also in vascular smooth muscle cells, but also on macrophages. That's being looked at. I think it's coming. The difficulty is you're talking about small areas with low levels of expression of stuff, and it becomes more difficult to detect those signals. As I'll just leave it with the last thing, though, is it may be that these very high sensitivity PET systems, the Explorer, the Vadis, whatever, take your choice, might work for vasculature very well because of the very, very high sensitivity.
Just to pursue that further, I was hoping not just for imaging of a specific vascular lesion, but developing an index that would talk about the inflammatory potential, that would be looking at the global image for the heart or the left ventricle.
Right. No, and I agree. That's what I'm getting at. I think is if we're going to do one globally, we're going to need a very, very highly sensitive instrument to pick that kind of signal up.
Sure.
And then the argument becomes, do you need that imaging for broad whole body risk if, let's say, bloods are telling you the same thing? What am I getting additionally from the imaging? Whereas from the imaging, you could get, let's say, in a coronary, you see a very highly inflamed lesion, and so maybe a 50% stenosis. You still might go ahead and fix that lesion, do a PCI, because I may not be able to, get to decrease the inflammation enough in an individual lesion. I don't know. I'm just speculating at that point.
Thank you.
Mm-hmm.
But since your group was one of the first to sort of have the availability of PET-MR, where do you see the role of PET-MR in sort of the cardiovascular space?
I don't know. I got to tell you, we've been just hasn't met expectations. Let's put it that way. And the biggest problem, at least with the current PET-MR, is that the MR is okay and the PET is not very good at all. I'm talking about performance. So, I'm not sure where it's going to fit. I'm just not. I guess the one place, though, where I do think it could have relevance is that when you think about molecular imaging, low expressing receptor or cells, the receptors are going after, so your signal's low. So motion becomes a huge issue. So your best motion correction algorithms, as I see them, are coming from the MR. So you could see the MR. I mean, it's a pretty expensive way to do it, but doing the motion correction to get the best PET signal you can from your PET. But you need a new PET-MR. I know Siemens is coming out with a new one. I don't know if GE is, but you need to get it, PETs that are getting up to the level of a vision or better if you're really going to go after these things. And so that to me is where it's going to be now. Beyond that, I just don't know, because I can't make the argument that I need the PET MR to co-localize, that I can't get that same information from fused imaging. You know, I'll leave one more place where it might have relevance is, you know, we do it here. I don't know if you guys do it. We do have a study ongoing doing external beam radiation for refractory arrhythmias. Now, if you really want to go after where do I want to induce or place that radiation, you could see where I need the MR for the late gadolinium enhancement, whatever other signal, superimposed upon whatever I'm using with PET to really co-localize that accurately. That is one place where I could see it.
All right, great. The hour's late, and I want to thank you for a great presentation and interesting discussion.
Thank you, everyone, for your attention. Thank you.
Bye.
Bye-bye.